If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. In today's episode, we're going to go through the NICE guideline on chronic heart failure, which was last updated in September 2025. Today's episode focuses on the initial assessment and diagnosis. The guidance on the remaining aspects of heart failure management will be covered over forthcoming episodes, so stay tuned. Right, let's jump into it. And as we have just said, today we're going to focus on how we diagnose heart failure. We will obviously begin by taking a thorough history, performing a clinical examination, and arranging tests to confirm the diagnosis. And we should start by measuring N-terminal pro-B type natriuretic peptide, or NT-proBNP, in anyone with suspected heart failure. Because very high levels of NT-proBNP carry a poor prognosis, we will refer people with suspected heart failure and an NT-proBNP level above 2000 nanograms per liter or 236 picomoles per liter urgently for specialist assessment and an echocardiogram within 2 weeks. We should refer people with suspected heart failure and lower NT-proBNP levels between 400 and 2000 nanograms per liter, that's 47 to 236 picomoles per liter, for specialist assessment and an echocardiogram too, but this time to be seen within 6 weeks. We need to be aware that an NT-proBNP level below 400 nanograms per liter or 47 picomoles per liter in an untreated person makes the diagnosis of heart failure less likely. We also need to remember that the NT-proBNP level does not differentiate between heart failure with preserved, mildly reduced, or reduced ejection fraction. When NT-proBNP levels are below 400 nanograms per liter, we should consider alternative causes for the symptoms. If there's still concern that the symptoms might be related to heart failure, we should discuss the case with a heart failure specialist. We also need to be aware that there are factors that can affect the NT-proBNP level. Factors that can reduce the level are obesity, African or African Caribbean ethnic background, and treatment with certain medications. These include diuretics, beta blockers, mineralocorticoid receptor antagonists, ACE inhibitors, ARBs, and angiotensin receptor neprilysin inhibitors. And let's just quickly say that angiotensin receptor neprilysin inhibitors are a relatively new class of medications used in the management of heart failure with reduced ejection fraction. At present, the only available one is sacubitril valsartan, which combines 2 mechanisms of action. Sacubitril, which inhibits neprilysin, an enzyme that breaks down beneficial natriuretic peptides. By blocking neprilysin, sacubitril helps with vasodilation, sodium excretion, and reduced cardiac remodeling. And then we have valsartan, an angiotensin II receptor blocker, or ARB, which helps counteract the harmful effect of the renin-angiotensin-aldosterone system by reducing vasoconstriction, sodium retention, and aldosterone secretion. Together, this combination of sacubitril and valsartan improves outcomes in patients with heart failure with reduced ejection fraction. Okay, going back to the factors that can affect NT-proBNP levels, we should remember that high levels can have causes other than heart failure. For example, pulmonary, renal, liver, or systemic disease, sepsis, COPD, diabetes, or liver cirrhosis. As we can see, the main tools to diagnose heart failure are the NT-proBNP level, followed by transthoracic echocardiogram. The purpose for performing an echocardiogram is to exclude important valve disease, detect intracardiac shunts, and assess both systolic and diastolic function of the left ventricle. Categorizing cardiac function is important because the treatment of heart failure will be different depending on the ejection fraction. We classify heart failure as follows. Heart failure with reduced ejection fraction when the ejection fraction is 40% or below. Heart failure with mildly reduced ejection fraction when it is between 41 and 49%. and heart failure with preserved ejection fraction when it is 50% or higher. We will look at the specific drug treatment of each of these subtypes of heart failure in the next episode. I'm going back to the diagnosis. Although transthoracic echocardiography is our first-line imaging option, if image quality is poor, alternative imaging methods such as radionuclide angiography, cardiac MRI, or transesophageal echocardiography should be considered. Also, although NT-proBNP and echocardiography are the cornerstone of the diagnosis of heart failure, we should also consider further investigations to assess possible aggravating factors or alternative diagnoses. These include an ECG, a chest X-ray, blood tests including renal, liver and thyroid function tests, a lipid profile, HbA1c and a FUBLA count. And we will also do urinalysis and peak flow or spirometry. We do this because we should always try to exclude other disorders that may present in a similar manner. Once a diagnosis of heart failure has been made, we will assess its severity, causes, precipitating factors, type of cardiac dysfunction, and any correctable causes. And in particular, for people with heart failure caused by valve disease, we will refer them for specialist assessment and advice. We should also review patients with a historical diagnosis of heart failure and manage them according to this NICE guideline, only if the diagnosis has been confirmed with an echocardiogram. If heart failure is still suspected but no underlying cardiac abnormality has been identified on imaging, we will refer to a heart failure specialist. So that is it, a review of the initial assessment and diagnosis of heart failure. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.